Hi everyone, my name is Rachel Moses and you are listening to the HP Leader podcast. This podcast is a series of COVID-19 lessons learnt from London, and today I'm delighted to be joined by an incredible bunch of speech and language therapists who are going to talk to us about their lived experience through the COVID-19 pandemic. Now, as usual, no one's claiming to be an expert and this is the only way to do things, but this is a great opportunity to capture what we've learned, what's worked really well, what challenges we've had, and how we can prepare for ever going through this time again. So I'm going to let the speakers each introduce themselves. If I come to you first, Jodi.
Hi there, my name's Jodi. I'm a senior speech and language therapist based at the National Hospital for Neurology and Neurosurgery in London, of course. And during COVID, I was in a variety of different settings depending on what week and month it was. So I spent some time working with our neurology outpatients, trying to keep them safe at home as the wave came towards London. And then I moved over to the Nightingale Intensive Care Unit and then over to our UCLH main ITU. So a mixture of experiences.
Thank you, Jodi. Alexia.
Hi, I'm Alexia. I'm a speech therapist with the background in critical care. I'm also the therapy manager at Barking, Havering and Redbridge University Trust in East London. I did predominantly work in critical care, but over COVID I was working in a workforce hub around moving staff to the acuity of wards.
Oh, fantastic. We'll definitely be picking up on that for sure. I'm Caitlin.
Hello, I'm Caitlin. I'm a speech and language therapist based in the Islington community team. So we cover community neuro-rehab, also intermediate care. I'm also the discharge to assess speech therapist for Islington. So that involves working with my social services colleagues. So my job during COVID was to basically get people home safely and keep them home safely.
Discharge to assess speech and language therapists. I love that. We'll definitely be picking up on that, Caitlin, for sure. Lauren.
Yeah, hiya, I'm Lauren. So I work at the Whittington Hospital. I have a split post at the moment, so I'm the clinical lead for the adult acute team, but I'm also the acting manager for the speech therapy service as a whole. And during the COVID phase or the acute phase, I was obviously doing the managerial side, but then I was also working on intensive care and also on the general acute wards as well.
Thank you. And Claire.
Hi there, I'm Claire Twinn. I'm Head of Speech and Language Therapy at Guy's and St Thomas's Hospital. My role has been Head of Speech and Language Therapy throughout COVID, trying to piece it all together and keep our services running.
Thank you. So wow, I'm so fortunate to be joined by such a diverse panel with so many years of experience and across the whole entire pathway. And for those of you that know me, I'm absolutely obsessed with speech and language therapists, particularly in the last, say, 5-10 years of my career. I've certainly learned so much. And how we're kind of going to do this podcast a little bit is to talk about each of the different areas and pathways, and how speech and language therapy has been absolutely imperative to COVID patients across that pathway. So a little bit about what the role normally is and how that's either changed or adapted or flexed within the pandemic times. And again, if any of you are listening to this and you don't have speech and language therapists as part of your pathway, this is going to educate you to exactly why you do need them. So I'm going to start off with the most acute phase, which is intensive care. So as we know, COVID-19 is a respiratory disease, and it created so many problems for a number of patients, with respiratory failure being one of the most critical. And we're seeing thousands and thousands of patients across the UK and being admitted into the critical care units, but obviously particularly London seeing a very sudden influx of patients needing critical care admission, and that involved intubation and ventilation. So Alexia, if I could come to you first, do you want to tell us a little bit about the role, like why do we need speech and language therapists in intensive care anyway, and what is the usual role and how we would prepare in kind of our ICU critical care SLT workforce for the pandemic?
Thank you, Rachel, and thanks for giving us a platform to speak about the great speeches do in intensive care. So our role has developed over the last 10-15 years, I would say, in intensive care. We are big advocates of communication, and within the intensive care setting that could be non-verbal communication, making something as simple as possible to communicate a message, whether it be with a doctor, a therapist, a family member, just so that you can have some kind of therapeutic relationship, and getting patients involved at the earliest possible moment in decision making, because then they're more likely to be compliant. But I think what the really the evolving side of speech therapy in intensive care has been around with what we can do with swallowing. So I think we've gained some real respect over the last couple of years with regards to how our swallowing anatomy and training has helped with tracheostomy weaning, for example, with getting patients eating and drinking earlier so that they don't decondition those muscles in the upper airway, and how we can sort of reduce the risk of the morbidities and mortality that is related to aspiration pneumonia. Getting speech therapy in at the earliest convenient time allows for less risk to be mitigated, I think, in those areas. So I think that's generally sort of the role. I think we play a huge role in weaning, and that's not just with tracheostomy patients when they're not on the ventilator, but as soon as we can get that tracheostomy in a patient and they're on a ventilator, you know, I'm always pushing the MDT. Can we get a speaking valve on? Can we get a speaking valve on yet? Because, you know, you get that therapeutic relationship with the patient a lot earlier, and actually their compliance is better. They can be part of their decision making, and you're not doing something to them. They're part of their own journey. So I think that's really, really valuable. And I think MDT colleagues really value that, actually, and can really participate in that, because critical care, if nothing else, is about the MDT. It's not about one profession leading the way. I think there is a huge team, if not family, in intensive care, and we've all got to respect one another and what we can contribute. I've worked with lots of physio colleagues with regards to tracheostomy weaning, with nursing colleagues who are with their patients 24 hours a day, giving that one-to-one nursing care. And I think we all have a valuable part to play. So that's what we've done pre-COVID. I think COVID was startling for a lot of people. There was plans around increasing bed capacity, you know, having beds less than a metre apart. It wasn't your one-to-one nursing, so that ITU family that we've been used to completely changed. So there was an adaptability, there was an agility that speech therapists alongside the MDT had to have. We all had to work as a team. I think we had great direction from the Royal College of Speech and Language Therapists. They were very upfront about saying that everything a speech therapist does, because we work with the upper airway, was an aerosol generating procedure. So nearly all of our regular work, if you like, was put on hold because we didn't know the risks around the infection rate or anything like that. We wanted to reduce it for other patients. So I think we kind of went on hold, but in that we learned other skills. And I think the agility and the adaptability of speech therapists really came to the forefront, what I saw during COVID. So whether it was getting band 5s in who aren't usually in the intensive care setting, so a junior member of staff, to do mouth cares to support the nursing staff to share the load, whether it was doing the family phone calls via Zoom. We are all now, well, I hope we are all a bit more tech savvy. I'm not sure I am, but I'm trying. So, you know, the virtual family sharing, I think, has been really good. We were advocates for that. Let's support our patients to communicate with the families. There's a case specifically that comes to mind was a daughter who remembers very vividly her mom being able to mouth "I love you," because obviously visiting restrictions were in, and all she wanted to do was to be able to do that, and she happened to do it on her husband's 70th birthday. So, you know, we were advocates for much more than just swallowing. And in the background, I think we worked hard to try and do the swallowing in the full PPE as soon as we could. Get the objective assessments. So we use endoscopes to evaluate swallowing. We call it FEES, fibre optic endoscopic evaluation of swallowing. As soon as we were able to get guidance on that from the Royal College, we've been able to implement that again. Locally, we implemented some things around weaning with tracheostomy patients. If a patient had 14 days post their last COVID positive screen, then we introduced cuff down trials to try and get the patient using their upper airway as quickly as possible.
Thank you. And I think that you've just touched on a point about ICU nurse staffing as well, because in the UK we often seen our ICUs move from a 1-to-1 nurse staff model to a 1-to-2, 1-to-3, 1-to-4, and even in some cases at the height of the pandemic, 1-to-6, supported by registered general nurses, RGNs is what we call these nurses, but they're not critical care trained. So having a ICU that can mobilise ICU trained therapists, we're really seeing some of those ICUs be able to manage the much more complex patients and also increase their ICU capacity safely, like you said, Alexia. So yes, Jodi, I'm going to come in to you now for some comments.
Yeah, I was actually going to pick up on some of the points that Alexia had made really well about our role on ITU, and just kind of drilling into my experiences of moving from 2 different ITUs actually. And what really struck me, I think, as a speech and language therapist working amongst speech therapists and the wider MTT is just how adaptable speech therapists are, and how they, Alexia talked a lot about the unknown risks associated with COVID, as not knowing how these patients were going to manifest further down the line. And I think as a profession, as a group of speech therapists, we are reasonably proactive, or very proactive thinkers, and we like to establish what the position is so we can manage the patient better further down the line. And there's a whole load of literature at the moment about tracheostomy tube sizes, selecting the right tube, and I think it was really interesting to be able to transfer those skills, not just with tracheostomy patients, but over to endotracheal intubated patients, so patients that speech therapists wouldn't ordinarily be involved with. We were seeing people who were sedated and tubed orally, and actually that's not a typical or classical remit for a speech and language therapist, and yet that's where we found ourselves. And it was really interesting to see just how much of our knowledge we could bring and share with a redeployed ITU team. So we know the airway, the upper airway, inside out. We know the pharynx and the larynx inside out. And actually all of those things we know about tracheostomy can totally be applied to this patient group that are sedated and ventilated as well. So getting the team thinking about their readiness for extubation is very similar principle to readiness for decannulation. So and we felt that we were playing a big role in upskilling and educating people about what that tube's doing, what will that look like when that tube comes out. So really valuable lessons, I think, and just really understanding what these bulbar presentations of COVID were. So we were seeing an awful lot of patients with neck and tongue swelling, and us trying to get to the bottom of why they were so swollen in their upper airways. It was just constant food for thought on the ITU about how is this going to look further down the line, and what can we do as speech therapists to manage kind of longer term consequences, even though we didn't know really where this was going to go. So it was great also just on the communication front, working with our OT colleagues, with our intubated patients who were on a sedation hold, so they were assessing readiness for extubation, and coming in with an OT to look at kind of responsiveness levels and cognition and their likelihood of tolerating that tube removal well was something that I really valued, and I'd never really worked with an OT on before. So again, it opened up the door of the critical care unit to really sharing skills and adding value, I think, to the patient's treatment.
Thank you. Completely agree. And you mentioned mouth care, and you're experts with the oral cavity as well, and that was massively neglected, I think, in some of our patients at the height of pandemic. And I think this is where SLT for me had a really important role in terms of not just education, but just the actual doing, how to clean a mouth properly. You know, we're all used to the pink sponges, but it was actually how to assess. So completely agree. Claire, can I come into you, please?
Yes, I just wanted to chip in actually on the ITU side of things, just in terms of the communication side of our roles. I think we had an additional layer of challenge with the PPE. I'm sure you guys will agree, Jodi and Alexia. I think that just added another layer of anxiety for patients in already a very challenging environment, but also with the absence of family there as well to facilitate communication. So I think actually we had quite big jobs on our hands in terms of both the mouth care side of things, communication, and obviously the swallowing and weaning side of things as well. But I think for many patients, a major source of anxiety was that communication and not being able to communicate adequately with their family. So facilitating that by any means we could, I think, has been a really key role. The other thing I was just going to mention is that kind of pressure, just reflecting back on that period, on therapists who were working in the intensive care environment, was the what's going to happen next bit. So from a sort of service perspective, we were trying to anticipate what we needed to do in terms of resource. What was the next step going to be? Where was step down going to be? What was that going to look like? What were we going to need in the community? And so we had quite a lot of pressure on therapists who were actually seeing these patients to say, well, what do you think? What do you reckon? You know, do you think this is going to be a long-term wean? Are we going to be discharging a whole cohort of patients out to the community with tracheostomy? How are we going to manage that? Do we need to think about upskilling staff? So I think there was a lot of kind of hypothetical chat going on at that point, and sort of desperation really to try and work out what the trajectory might be for these patients. And I think as speech and language therapists and guardians of the larynx and pharynx, seeing patients proned for prolonged periods, we started to really think, oh my goodness, we're going to see quite significant laryngeal injury, and that post-extubation dysphagia side of things could be quite complicated and could result in quite a high demand on our services going forward for who knows for how long. And I think that pressure was quite intense at that time, not just on the kind of the doing and the actual treating patients and working with patients, but actually those kind of questions that were coming at the therapist left, right and centre to help us plan. So yeah, I just wanted to chip in with
Claire,
that.
and that's really important. And I remember sitting doing a podcast at the beginning of or the middle of March, and we were writing papers and we were learning from the Italians, and we just never thought we'd do trachees in this patient group. The average length of intubation was 7 days, and then lo and behold, we seen a completely different patient population, didn't we, in the UK to some degree. And like you said, especially for London, you know, COVID hit London at pace, and the difference in 7 days for the intensive care units was significant. And then, like you said, everyone then trying to plan post. And I think how the ICUs responded in London is just incredible. So, and that includes obviously us as a therapist as well. So Alexia, can I come down to you, please?
Yeah, just something I think to highlight, just, you know, speech therapists did this in the critical care when everything was changing, when we were working on a different model completely. And not just speech therapists, but of course all healthcare professions were doing this at a time when we didn't really know what COVID was. So was PPE safe? Was there going to be enough of PPE? Were you wearing the right mask? You know, I think what you said just then, Rachel, about it being done at pace is true. It was done. It just so happened the week COVID really kicked off in London, I was shadowing the chief nurse of the hospital. So some of the meetings I were pulled in on, the gravitas of what people had to do in a time they were looking out for their own safety as well as their patients, and the professionalism of it all was, I think it was phenomenal. I think speech therapy and the wider NDT did an amazing job. The NHS was brilliant during that time.
Absolutely, and our survival rate in some of the centres was absolutely phenomenal. You know, the GSTT data, for example, has been widely, you know, reported on having this 70% survival rate, probably over that now, is incredible. So that moves us on to the next part of the pathway, which was the ward environment. So we have on the respiratory wards, on the respiratory medical wards in our hospitals, so we stepped down all elective surgery or non-essential services, and that freed up capacity not only within our critical care units to extend our critical care units, but also to extend our respiratory and acute wards. So on our wards, we had a mixture of patients with COVID. Here was step down ICU, so we're ICU COVID survivors, which was a whole entity in itself. We then had patients who were admitted through the emergency departments or from community with a ceiling of treatment of maybe non-invasive ventilatory support under that umbrella. And then we maybe had patients that were admitted who were for supportive therapy, oxygen therapy, etc. And within those cohort of patients, there was a wide range of complexity. We might have very young patients with no comorbidities to patients who had multiple comorbidities, existing underlying disease processes. So real variety of who needed our help. So if I'm going to come to, I think it's Lauren, just to tell us a little bit around the role of the SLT in that area, maybe what your role normally would be and look like. And we've already mentioned some of the investigations that you'd depend on or you'd rely on, particularly to assess dysphagia, swallow, and the upper airway. But kind of what is your role and how did you adapt?
Yeah, I mean, I guess it's just building what is being said, you know, that we have a huge role around communication and dysphagia, and that role continues from intensive care all the way up to the wards. I think when you hit the wards as well, we have a role around a lot of, like we might have a role around palliation as well, and that's actually something that we were involved quite heavily in, a lot of those discussions in the COVID area. For us on our wards as well is that we do actually have tracheostomies, so that still continues, and that was pre-COVID and was as well as during COVID. I think it was really challenging on the wards because you say there was just such a range of people, there was such a range of diagnosis. We were seeing these, as Jodi touched on before, like these bulbar signs showing. We also had, you know, patients that were green, so that we classed as green, so didn't have COVID. So we had the logistics of trying to navigate how we see someone who's COVID positive, and then how we go see someone who's COVID negative. That was all quite difficult. I think one thing that we saw a lot of during the COVID times was how great the speech therapy skills were really helpful in the fact of we know a lot around the breathing swallowing mechanism, and actually that was significant because a lot of these patients were on some form of ventilation, whether it be Optiflow, whether it be CPAP. You know, we were seeing them up on the wards. We wouldn't normally have that, particularly at the Whittington Hospital. They would be in intensive care units. So having that background in our knowledge was incredibly helpful, and it was really helpful for the nurses too, because we could actually go offer the nurse some respite while they go off and just take a 5-10 minute break or whatever they need to just kind of regroup. I think during the COVID times as well, we saw a lot of delirium, whether that be intensive care or critical care induced, or whether it just be as a result of what the patients are going through. And so there was a huge role with speech therapy around that. And we're also seeing a lot of things like post-traumatic stress. Again, those that maybe have been through intensive care and where maybe they might stay in intensive care for a bit of time to kind of regroup, they were being shipped out quite early to the wards, understandably. So we're involved with a lot of that and just trying to talk the patients through. Yeah, I'm trying to think what else. There was so much. I feel like I haven't structured this answer very well. Yeah, does anyone have anything else?
That's so helpful, and that's a really rounded kind of summary, I think, and it's the adaptability of just being able to treat what was in front of you at the time. So sometimes, like exactly what Claire was saying, we're trying to plan, we're trying to know how many therapists would be needed for each ward, or And it was really just about understanding your workforce and the skills that people had, and then where maybe the gaps were as the weeks went on, and then trying to provide that education or skill set to staff as it came along, for sure. Jodi, can I come into you?
Yeah, it was interesting listening to Lauren speak, actually, because what it felt like, certainly from step down to ITU, is it just started feeling a little bit less nuanced and a bit more messy, because there was everything on the acute wards. And my experience from ITU to step down or the acute wards was that on ITU I had a plan. I knew what I was dealing with. It was COVID, and it was ventilated patients or trachea patients. And then for me, the acute wards were kind of almost a mixture of two arms. So there was the step down COVID wards, which we're seeing, in my experience, seeing quite a few tracheostomies coming through, and some of the slower weans who were maybe off the invasive ventilation using NIV. But what I did find later, like as the kind of wave passed through, that actually the patients were then actually starting to get decannulated and managed on critical care because the bed spaces were available. So actually step down became a slightly different beast. And our step down, I worked quite closely with a speech therapist on step down, and we were passing down from ITU, and she was very open about how the patient demographics certainly changed in that kind of 8 to 12 weeks, and they looked very different, and her skill set had to change to match that changing demographic. So she was initially trachea weaning, but then she was actually looking at cognitive communication assessment for discharge later on in the pathway. So but one of the thing that really struck me, actually coming back to Queen Square, was, and all credit to my colleagues who were at Queen Square, who were actually managing neuro patients with COVID on top, and that's where I could see some of the more raw exhaustion of juggling those dual diagnoses and unpicking, what am I treating here? Am I treating COVID? Actually, I can't deliver the care that I would normally deliver for this patient, because we need to get them out of hospital. And I think the emotional turmoil that I could see in my colleagues of not being able to deliver the care that they wanted to deliver on the acute wards because of COVID was very real and very raw, and I think that still exists certainly amongst the MDT, and that feeling actually of guilt that you weren't able to do your job well because you were covered in PPE and you were being told to get these patients out. But I mean, again, kind of looking at the speech therapy skill set in that group, I think as a profession, again, we're really good at asking questions and we're really good at differential diagnosis. So what I could see in my colleagues stepping up and saying, this isn't just COVID, there's something else going on here as well. And they might have come in with COVID, but there's some undetected disease process going on. And so I think the contribution that speech therapy have made is a part of that differential diagnosis, that continuum as you leave ITU or step up to ITU. They've played such a crucial role in raising concerns and getting people looked at in much more detail, because the pathways were quick, weren't they? They were just so quick. So
absolutely, and to kind of reassure you, that has been brought up on the other podcast as well, this therapy guilt, yeah. As well. Alexia, can I come to you? Then I'm going to come to you, Claire.
Yeah, just something that both Jodi and Lauren have touched on. I think the complexity of the patient, once they got out of ITU, where you had a lot of resources that had been moved into, was more challenging. So we saw a higher increase in patients stroking out as a result of having COVID. So the stroke services, where we'd redeployed staff maybe to the critical care area, were then needing to move back into that area to provide a stroke therapeutic service. And then so you've got this respiratory condition. On top of that, you have the neuro condition. And then on top of that, we saw things like delirium, the PTSD with no family support. And with the complicated by fatigue. Fatigue has been a huge thing throughout the COVID pathway. So I think, speech therapy and our colleagues have managed this concoction of presentations really well.
Absolutely. Claire, did you have something to come in with there, or did I?
I think, yes, sorry, I think actually both Jodi and Alexia have touched on it, but I think it was more around that role in differential diagnosis. I feel like, and this is just a personal reflection really, but at the beginning of the pandemic, as things started to ramp up, the assumption for anybody presenting in the ED with a respiratory disorder of any sort was this is COVID. The whole kind of question mark around aspiration, could there be a dysphagia here, seemed to sort of disappear off the map for a little while. And we certainly went through a very strange phase here where we felt like we were waiting for a tsunami to arrive of referrals. And there was a little bit at the very beginning where it was very quiet. And then we then caught up with those patients a little bit further down the line. And that would have been on the acute medical wards, so sort of what was sort of OPU type setting, but actually was then either a COVID suspected ward or a COVID positive ward or a COVID negative ward. There was this group of patients that sort of escaped our early attention that actually normally we're in there right from the beginning. There's a swallow screen done at the front door by the nursing team, and those referrals start to come in. But there definitely felt like there was a little bit at the beginning where actually that disappeared off the differential diagnosis list, and those patients suddenly became a bit of concern for us, and certainly from a nutritional perspective, our dietetic colleagues did, I don't quite know how they managed this in terms of resource, but they actually audited nutritional intake on those acute medical wards, and it was absolutely horrific and quite horrifying to see that actually it had sort of gone off the agenda. The sort of basic sort of fundamentals of care, thinking about nutrition and swallowing, had sort of been bypassed by COVID. And so I think our role as educators really kind of ramped up at that point. And I think we had to spend quite a significant amount of time kind of resetting everybody's minds. So yeah, it was just really to pick up on that.
Absolutely. Lauren?
Yeah, I mean, it's around that differential diagnosis as well of actually, I don't know how you guys found it, but the instrumental assessment side of things, that was really challenging, because whereas normally if we are trying to differentiate between, you know, we're trying to work out what maybe the cause of the, if there is a dysphagia or the cause of dysphagia, we would head to instrumental, and actually that was really challenging because our fee service initially was stopped by college, and rightly so. And also the video fluoroscopy was quite difficult to access, particularly if the patients were COVID positive. So that was quite a challenge for us. I think as well, touching on what Claire was saying, particularly that initial phase where we were not seeing these patients come into hospital being referred to us, maybe. I think that was one thing that really worried us, and I think Caitlin might touch on it as well, probably will, is that these, for example, our oldies who are sitting in the care home, who we normally see come through the hospital at quite a fast rate with things like aspiration, we weren't getting those referrals. And in fact, those patients weren't coming to hospital. And that was a really worry, a huge worry for us in the acute, but also I know in the community, and I know Caitlin might touch on that.
Absolutely. And that does fall in quite nicely with the next part of the pathway. Now, Caitlin, I'm going to pick up on your comment before about a discharge to assess speech and language therapist, and I'm shamefully admitting here I don't think I've ever heard that.
Right, so discharge to assess. Yeah, so it's a pathway, it's new to Islington. Only in the last year or so we've really been having it going. So my role is to see people within 2 working days of discharge, or 2 working days of referral from the acute. So the service aims to reduce readmissions and to reduce the length of stay overall. So I go and see people with communication and swallowing needs who need quick follow-up in the community, follow them up for a short time and refer on if they need. So that's in conjunction with social services. So what they'll do is there's social services, physios and OTs that will go and do an initial assessment in the person's home immediately post-discharge, set up what's needed, and if any speech needs are identified, I go in, or my team goes in. So that's my role. Well, that was my role pre-COVID. That pathway's changed a little bit, but essentially I do the same thing at the moment. I pick up any hospital discharges, see them with a very quick turnaround. I also see general community patients, so that's referrals from GPs, nursing homes, any other, district nurses, any other community-based referrals. Lauren, you hit the nail on the head. It was a bit of an interesting beast, the community setting during the pandemic. We did have quite a significant drop in referrals at the start of lockdown, at the start of the, when it really hit. And we theorised a lot of reasons why this was. I think, Lauren, you're right in that I think there was such a focus on COVID, that there were potentially other people sitting in care homes, in their own homes, not being referred. One, because they weren't accessing services. They were told to stay home. They were told not to go to A&E. They were told not to go to their GP. And I think a lot of people took that really to heart, for better or for worse. So we weren't getting a lot of GP referrals. Nursing homes, they really struggled through this pandemic, and they still are. And for that reason, I think a lot of nursing homes didn't want a lot of people coming in. So our role, we really had to advocate for SLT, and we really had to say to nursing homes, to GPs, to regular referrals, hey, we're still here. Hey, we can still offer a service, and to really just get these patients back on their feet. Because we're not only seeing post-COVID people, we're seeing post-stroke, we're seeing our regular COPD, we're seeing our regular dementia patients, we're seeing everything that we usually see, and these people still need follow-up in the community, might still need a bit of help. So we've had to really advocate, and it's actually only really now, at this stage of the pandemic, that we're really getting all those referrals and starting to get really busy. I think we're still reaching our peak. Whereas I think a lot of the acute and ICU teams have had a really tough time in starting to wind down. I think now it's coming onto the community.
Mm-hmm. And what kind of things, what kind of interventions are you having to do? What kind of side effects are you seeing from COVID with relation to communication or swallow or?
Clinically? Yeah, clinically. So we're seeing it's a bit of a mixed bag. Our acute colleagues have done such an amazing job of getting these people well and getting them home. We're seeing, I think my physio colleagues probably say more about the breathlessness side of things, but I think we are seeing a fair bit of breathlessness. We are seeing a lot of post-COVID anxiety. So we're working with our psychology colleagues to really dig down into that. We're seeing a lot of, I saw a lady today actually who's had smell and taste changes and a decreased appetite because of that. So we had to do a bit of education around that. So definitely, and voice as well. So we're seeing some people with new voice difficulties, and we're liaising with our voice SLT colleagues around that. Dysphagia wise, breath swallow relationship changes and how that impacts on the swallow. But yeah, I think it's really been patient specific. We haven't seen anything, a huge pattern yet, but I don't know if my other community colleagues have seen something different.
Jodi, can I come into you there, please?
No, yeah, it's interesting, Caitlin, listening to you talk about the COVID patients who are post-discharge or still at home in the community, and to me that feels very much like a beast that we haven't quite understood yet. We're still working out what that looks like further down the pathway. I know what has kind of what made me kind of step back is looking back at the literature or the proposals as we were preparing for COVID, about what we were thinking we were going to expect. And I know that dysphagia and PEG planning and gastrostomy, there was lots of talk about people living with, really complicated issues with their swallowing. And actually, for me, I haven't seen an awful lot of patients with an awful dysphagia at this point. So it's what I will be interesting, and I know Claire's got a post-COVID voice kind of clinic, and I wonder how many patients we're going to start to see with upper airway dysfunctions because of and breathing pattern disorders, and any kind of issues with stenosis and airway related things that our speech therapists who are specifically trained in airway dysfunction would be able to pick up. What we don't know about is what damage of those tubes done that have been in for weeks on ITU as well. So for me, I don't feel like I quite understand what our post-COVID patients look like and what our role is going to be. But just on a kind of similar note, I guess, what really struck me as a speech therapy profession in the step down or the community and outpatient setting is how hard our colleagues were working on the non-COVID pathways in that time to keep people out of hospital. So when you said, Caitlin, we're still outreaching to care homes, people with dementia, and certainly that was the other part of my role. I spent a lot of time on telehealth and video calls, and the gratitude of our patients who had been told to stay at home and not outreach to the NHS was overwhelming, and I felt like my role at times then extended into almost a counselling type role, because you're managing people's anxiety who've been told not to reach into the NHS. So it was drawing on a completely different skill set on a Monday compared to your ITU session on a Friday, for example. But I think we mustn't forget that group of speech therapists that were doing all that non-COVID essential work and keeping these people out of hospital in the first place, because I think the risk of our population with cognitive disorders and aphasia and language problems is that it's so crucial that these people understand what they're doing and why they're doing it, and that was our role, to communicate that well and make sure that those patients had a lifeline to contact whilst we were doing all the other work in the hospitals.
Absolutely, and some of the, I think the one of the challenges has been quite variance in terms of what centres have found, like bigger centres who've had larger patient numbers. So some patients have experienced some airway difficulties in that immediate post-extubation phase, needed reintubation. Some have had delayed airway incidents. And some of my colleagues in some of the tertiary centres outside of London, Sarah, for example, at Whittington, and are experiencing airway stenosis and airway insults 2, 3, 4 weeks down the line of discharge. So because we're still actively discharging patients, we still have intubated COVID patients at the moment, we don't really know the full effect. And I think that's why this surveillance option, or making sure patients are followed up in some of the clinics, is really important, because you guys as the airway experts will ask questions or look for keys or triggers or non-verbal cues that other professionals just wouldn't look at. Caitlin, if I can come to you, then I'm going to come to Claire, thanks.
Yeah, no, I agree, and I think that was a really wonderful point made there as well, is that the nature of the community job has changed quite a lot, in that we are doing welfare checks, we're keeping the people on our caseload we'd usually see, making sure they're still okay. Also, we are doing telehealth, because there's a big difference between treating someone in a hospital setting and then going into their home. There's a whole heap of other risks, catching the bus to someone's home, whether they want us in their home, and Ppe and all those sorts of things, doing a lot more transdisciplinary work. I've been taking arm measurements for my dietetics colleagues who aren't doing home visits at the moment, liaising with psychologists to help manage some of that anxiety. So while clinically we're still not 100% sure what we're facing in the community, in terms of the structure of our day and the kinds of the nature of our work, I agree, it's really changed, and I feel that I've become a more well-rounded community therapist based on it. But yeah, I mean, clinically we're not sure, but we've done a lot of new innovation around telehealth and transdisciplinary working, interdisciplinary working, multidisciplinary working.
Claire, if I could come to you, thank you.
Sorry, I've got a little list here, but I'll try not to ramble on for too long. Just points that you've all covered already, actually, but just wanted to talk a little bit about the voice pathway that we've set up. And we're quite fortunate here at Guy's and St Thomas's. We've got our voice service on the Guy's site. And so we were able to actually use our specialist therapists in those areas. We actually redeployed a couple of them to ward work, which was quite a departure from being in an outpatient clinic to donning the scrubs and the PPE and going onto the wards, but really took advantage of having that skill set available to us and did some team training on perceptual voice assessment so that we could actually set up this pathway for patients who are presenting with dysphonia in the acute phase, with a measurement when we first assessed the patient, and then a measurement on discharge. So we took a perceptual rating. And those patients are now on a pathway where they're being followed up by the voice team. So it'll be really, we don't know yet what the outcome of that is, but it'll be really interesting to see what the sort of picture is a little bit further down the line. The other thing I just wanted to mention was our community colleagues, and I don't know whether Caitlin, you may have seen some of this as well, and you touched on it briefly, but they have been getting referrals not necessarily from hospitals, but from community, with patients who have had COVID but are presenting with new cognitive communication disorders. They haven't actually touched an acute setting at any point, and I think that's a big unknown actually for all of us, or all disciplines, and certainly something that appears to be more of a theme as time marches on, that there are people out there who've had COVID, not been admitted to hospital, and are symptomatic, continuing to be symptomatic sort of 6-8 weeks down the line, in relatively sort of fit cohort of patients, right across the board, but particularly those kind of fitter, younger patients that you just wouldn't expect necessarily to have ongoing issues. And I think we're going to see a bit of a surge in referrals, both into acute specialisms, but also in the community for those new kind of presentations. The other thing I just wanted to touch on was the cancer population. So at Guy's, we have our cancer centre. We have a big head and neck cancer service and an oncology service running out of Guy's. And I just wanted to pick up on something, I think it was you, Jodi, that mentioned that phrase therapist guilt, which we all have in large doses. And I think during this period, those therapists who work specifically in cancer have really, really struggled to grapple with how we can continue to support our existing patients, but also what was happening to patients who were out there in the community with new symptoms. We know they weren't presenting to their GPs, they weren't calling 111, that was not the government directive, and we're just now starting to feel the sort of brunt of that with people starting to come forward now that confidence levels are up. We had some significant challenges with making sure that we risk managed our existing caseload, particularly our laryngectomy patients, those with a voice prosthesis that are dependent on coming in and out of hospital as and when they need to for a prosthesis change, which of course was fraught with difficulty in terms of PPE. It's an aerosol generating procedure, there's high risk to them, they're a shielding group, we couldn't get them in, we couldn't get out to them, there was lots of work that we had to do around that at pace, and I think that's a kind of theme of all of this experience, is everything has been at the most ridiculous pace, and it's only now you start looking back on what's changed, you realize the mountains that you've moved to get around these issues, but we're also starting to see the fallout, and I think it's a really difficult time for therapists across the board, whether you be in the community or in the acute setting. In the acute, I think everybody is kind of exhausted, for one thing, but also thinking what's going to come next. And that's a big challenge for us all. But I think in the community, there was initially quite a lot of waiting and a lot of what is it going to look like? What do we need to be ready for? We know we need to be ready, but what does that mean? And now starting to see those referrals coming in. And our stroke unit, for example, I can remember kind of early days in COVID, we just seemed to have 1 or 2 stroke patients on our very busy normally unit. And I know that was the same across London. So there was an awful lot of therapist guilt around that as well, not that it was necessarily anything to do with us or we could do anything about it, but that there must be cohorts of patients like you touched on, Caitlin, our normal kind of frail elderly, our stroke population, our cancer population, who are sitting out there with needs that weren't being met, or even acknowledged or recognized at that point via a GP. So I think, you know, there's so much that we don't know yet, and I think if we were to repeat this in a year's time, that's not a suggestion, Rachel, but I think if we did, it'd be very interesting to see what our thoughts were and what our data was showing at that point. Yeah,
absolutely. And you're involved in the follow-up side of things as well, in terms of once patients are discharged in the follow-up pathways, and I think the skeleton pathways are available. I'm sure they've been circulated on the internet.
they have, yeah.
But do you want to just tell us a little bit specifically about the SLT rule with regards to that?
Yeah, I mean, that's an interesting one actually, because we haven't previously had funding for a therapist to sit in our ITU follow-up clinics, although we've got fairly robust referral pathways set up. I think, and I suspect this is probably a common experience, that there was all of a sudden a bit of a rush to talk about rehabilitation and follow-up sort of in the middle of the pandemic, really, as things started to roll out. Everybody wanted data. All of a sudden, everybody was chasing our data, wanted to sort of start putting together kind of research projects and setting up follow-up. And one of the struggles that we've had in therapies, not just in speech and language therapy, is kind of keeping a handle on all these different pockets of follow-up that were starting to emerge. And before we knew it, we had sort of respiratory consultants doing follow-up clinics using telehealth, working their way through vast numbers of telephone calls to patients, but without necessarily having kind of consulted with therapies first, so that we could do that kind of well-rounded approach that we would all prefer, and make sure that we were capturing all the needs that those patients might be presenting with. So I think it would be unfair to say that we had that nailed. We certainly don't, but we have made kind of great strides in terms of getting involved in some of those follow-up clinics where possible, as soon as we were able to release staff to do so. And I think there's lots of learning that's come from that will be, well, it certainly is now very embedded and will be there, for the future. I think it's I can remember at one point feeling a bit precious about rehab. Everybody was talking about rehabilitation, but everybody was using a slightly different definition. And so I think there was a bit of a confused message going out, and certainly making a lot of therapists very anxious that we were potentially missing patients, and not wanting to overload this cohort with multiple phone calls or attend anywhere calls, virtual calls, whatever means we were using, because all of a sudden we were interested in what was happening when they got home. So I think that's been a bit of a monster in my mind to kind of get a grip on. And again, it comes down to the speed at which people were trying to do things. It's just been crazy. But it's learning. There's always learning.
Thank you. I mean, even that in itself is a learning exercise for me, Claire, so thank you. So I'm going to start wrapping this up now, and this is when I really want people to think about summarising things they've learned that they do again, like heaven forbid, like you said, Claire, we're ever in a situation where we are approaching a pandemic, when we know a pandemic's going to hit, if we go through second surge, which obviously from a UK perspective, we're worried that might be around winter time. How can we as kind of as HP leaders, if you like, prepare our professional workforce for potential redeployment? Again, how can we make sure we keep that, education, that learning cycle, people cross-skilled, and then also just about any significant lessons learned that you guys want to share that you think will be really powerful for our listeners. So Caitlin, I'm going to come to you first.
I think for me, like I said, we're still learning. I don't know how much what all of our learning is about, but the one thing that I think that I've taken away from this experience, and I think would be really, really useful to hang on to, is liaising with all of our teams. So in the community, really getting a good relationship with our acute teams across hospitals, but also our wider MDT, physios, OTs, dietitians, because we can really support each other clinically and really focus on patients throughout the care pathway, but also just for our own mental health and support. We've been really lucky to have some really great relationships even across boroughs in London, just to check in once a week and see how you're going, because if we're not doing very well, our patients aren't doing very well.
Thank you. Claire, looking to you.
Yeah, I mean, I think there's so much that we can take away from this experience, isn't there? But I think for me, the overwhelming sort of success story from my perspective was actually just watching how teams across all the kind of professional groups pull together as one, in the face of the crisis, and in the face of a challenge like we've never known, and one that came at us so quickly. So I think there's a lot to be learned from that, and I think a lot of relationships have been made and cemented, which would help us, heaven forbid, if we do face another situation with COVID hitting, particularly in the middle of winter, which doesn't even bear thinking about. But I feel like we have some really robust pathways and really robust relationships established now that will help us with that. I think staff well-being for me is a biggie, and I think it will be for all of us. And it's difficult to kind of qualify exactly what that means. We use the term quite loosely. At Guy's and St Thomas's, we were very lucky with the wellbeing offer that the trust kind of came up with so quickly, supported by so many other different elements, but particularly by our charity. But it's about what wellbeing means for individuals, and I think that's my biggest kind of take home, is that what does it for one person might not do it for somebody else, and it's about being able to bespoke that kind of well-being offer and recognize that different people need different things, and that's actually okay. We did a few bits and pieces around well-being, and actually one of the things we did was sort of cancel all our in-service training, our CPD time, and transferred that into a dedicated sort of hour for well-being. And members of the team did different things with that hour, and I think that's really important, having that flexibility. And that was certainly my learning, is that you can't just deliver a well-being session. It's not a medicine, it's an individual business, and that for me is something that I feel I've really learnt from the experience of managing a big team through this pandemic. So yeah, that would be my kind of take home. And data is the other thing, which is, with the benefit of hindsight, I mean, we did kind of collaborate very early doors with our therapy colleagues and try and pull together a really comprehensive data set across therapies, so that we weren't doing duplication as far as possible. But I think the challenges of doing that alongside dealing with a response that COVID required were quite huge. But I think the value of that now, that we have that to look back on and draw on for experience and to guide us with our future modelling and planning, is absolutely invaluable.
And if there's one hospital or one trust that collects data, Claire, it's definitely GFCT.
Oh, we love our data. Yeah. Can't beat a spreadsheet.
but look what you've got to show for it. I mean, it's incredible. Absolutely. Lauren, can I come to you, please?
Sure. I just kind of want to I guess build on what other people have said, but I think that biggest learning point for me really has been the AHP skill mix, and I think most people will agree that the AHPs have really been put on a platform as a result of this, but also to toot the speech therapy horn, that actually I think we've highlighted that a lot of our skills are transferable across many different settings, across all sorts of different disciplines. I think we've been able to input into all sorts of different areas where maybe traditionally it's been a little bit hard to kind of get our foot in the front door. I think this has kind of helped pushed it, which is great. So yeah, I'll leave it there.
Thank you. Jodi, and then Alexia, I am coming to you to finish off, so get prepared.
Yeah, I think it's really difficult to actually list the lessons learned, because I just think there's just been a huge ball of experience. And I think one of the take homes for me is just how adaptable and pragmatic our profession has been in this pandemic. The spectrum of skills that our profession have demonstrated is incredible. And I think I guess one of my kind of take homes for next time working in a non-COVID neuro centre would be to make sure that you kind of have your house in order before you jump into kind of adrenaline mode and COVID mode, because I think what's really exhausting now for our staff is that we're re-entering our tertiary service, that is neurology, and people are really tired and they're exhausted. So picking up a service that was essentially left and trying to restart that is really difficult. So I think one of the things we did as a speech therapy team was make sure that our house was in order, so it was ready to pick up when we came through this wave of the pandemic. Because I think that would have been absolutely exhausting to pick up a dropped service essentially. But yeah, I think big hands up to all of the MDT, because I think it's been a huge learning, exhausting experience. And I think if we can take the adrenaline slightly out of it next time, I think, and be able to approach things in a slightly more measured way and learn from what we've learned this time, which we've spoken about for the last hour, that's a win from as far as I'm concerned.
Absolutely. Alexia.
I think I would second every single point that has been made so far. I definitely have to give extra points to the fact that Claire mentioned data. I'm a bit of a data freak myself, as anyone who knows me will know. But I think the biggest learning point for me during COVID was the human element, whether that's the human element of what our patients were experiencing and the need for that. You know, we are social creatures and we can't ever forget that, whether we are patients, whether we are professionals, clinicians, whatever. So I think the human element and how people responded to that human element really is what's got us through this pandemic. So whether that be offering psychological support, you know, doing a daily huddle at the beginning of the day, at lunchtime, at the end of the day, having rooms that are deliberately put aside for quiet time if staff need to take 5 minutes, sharing that workload, making sure no one's feeling overburdened. Personalizing PPE, something as simple as the Hello, My Name Is initiative, and putting that on some PPE so patients aren't terrified of seeing this monster and all they can see is eyes. You know, if you've got a picture of yourself, you know, I think the benefits of that. So I can't stress enough how important I think, you know, yes, it was adrenaline fueled. Yes, we were in the life-saving response as soon as we knew it was coming, especially in London where where it kicked off massively within a matter of days. But the human element of it, how we respond, how we receive, how we manage change, all of that I think is fundamental. And speech therapists are they're brilliant. They are resilient, they are agile, they're the innovation that I think we've seen during COVID, and I'm not taking anything away from our MDT colleagues, but we are specifically talking about the fantastic profession we've all gone into. I think speeches are so innovative, and we're big advocates. We get in, we don't mind a bit of networking here. If we can get our, you know, ITUs that never had speech therapists in before, were like, come on, get in, because we were sharing the burden with our nursing colleagues. So I just think that the human element needs to be remembered throughout COVID for our patients and for ourselves.
Absolutely. Yeah. For the speeches. Claire.
Sorry, I think that's my hand up from before, but actually I'm just going to add one thing that actually, in terms of what would we do differently, I would just love it if we could have masks that you could see through, all of us. Now I know that means the paper hoods, which are not the easiest things to wear, but I think for our patients, and I think we'll learn more of this as we go forward, that communication challenge, much as we did as much as possible to try and mitigate that, actually hearing each other, let alone as a patient in a bed with oxygen noise to compete with, as well as everything else, was just hugely challenging and frightening. And particularly if you're delirious, and heaven only knows what they thought they were seeing. But I really think that as a profession, if we could champion for speech and language therapists, first off, maybe just as a communication specialist, to try and push that kind of agenda around having the masks with a transparent face piece so that they can actually see our faces and read our lips. I think that would be my wish. So if you could sort that one out, Rachel, that'd be great.
Well, there is a manufacturer. Someone tagged us on Twitter actually, just today at some point actually, about a manufacturing firm that's going large with the perspex complete sealed. I think that's been the problem, hasn't it? To get a breathable mesh type fabric that is also see-through. But yeah, you might have your wish, Claire.
Great.
So I just want to say a massive thank you to everyone on the panel tonight, and I think the real takeaway points for me has been around not forgetting the basics of each of the professional groups, and from a speech and language perspective, that's even as basic as mouth care, something that's really was neglected, I think, in the first few patients that we've seen in terms of when at the height of pandemic. Jodi, you mentioned the swollen tongue, the swollen open airways. If people are extubated with horrendous mouths that are so painful, we know there's a nutritional deficit, we know there's an appetite and taste and a smell. consequence of COVID, then this whole cycle of malnutrition continues. Then it's more complex stuff around weaning, about laryngeal injury, being able to assess, leak tests, etc. And so important. And then tracheostomies, which we know we had to perform in this patient group, and what that means, just not in the acute phase, but the long-term phase. Everything you guys talked about, communication and dysphagia, and even though we didn't see a lot of long-term dysphagia type needs, it's that screening, isn't it? That discharge to assess that you mentioned, Caitlin, and then the signposting if you do have people who are more high risk, because these people didn't want to stay in hospital, they wanted to get home. And then everything you touched on, I can't remember who touched on, you know, the end of life kind of palliative role of the speech and language therapist with regards to communication on needs, and then that cognitive wraparound as well, that overlapping with our occupational therapists and psychologists. And obviously, being a physio myself, the massive role that speeches have working alongside physios throughout that entire pathway as well. And like I said, certainly in my last post, I couldn't have done my job without speech and language therapists for sure. So massive thank you. I hope you've enjoyed this, and thanks so much. Take care, everyone.